Good afternoon, everyone. It is now 1 o'clock. Just so we keep to a schedule, we are going to kick things off right away today. So with that, let me go over to my deck. Okay. So before we get started today, just a quick welcome. So good afternoon and welcome back to day 2 for the fall 2024 CCSQ Data and Analytics Data Camp. My name is Julie Amdy, if you didn't join us yesterday, and I'll be facilitating our event. And then I also should have mentioned yesterday, I'm also joined by Laura Harb. She is my backup, but she also has been dropping links in our chat throughout all data camp, and we'll be doing the same today. And if you had the pleasure of talking to her and all of our planning and prep, she's been doing a ton of work behind the scenes. So she's been a tremendous help throughout data camp. So she is here with me today as well, helping to facilitate there as well. So just a few reminders as our speakers present, please remember to stay muted to minimize distractions. If you have a question during our presentations, please submit it using the Zoom chat feature. And at the end of the session, the questions will be answered by our session speakers. The only exception there is sometimes during a demo, I know that our speakers will occasionally look at the chat in real time, want to go ahead and answer any questions that pertain to that spot. But typically they are going to be saved for our Q&A portion at the end as long as time permits. So with that, let's go ahead and kick off our agenda for the day. So our very first session that we're about to begin is CDR Medicare claims. And then our next session is going to be SAS to Python conversion, introduction to SAS to PyTool. Then our third session of the day is introduction to data, best practices. And then our final session is going to be object-oriented programming 101. And then I know says here a 10th session, but it really is just a small wrap-up session with some closing remarks by Ken Howard to kind of wrap things up and thank everyone. And that will be happening from 4 to 4:50 today. So as you can see on our schedule, we do have some built-in breaks. Yesterday, a couple of our sessions did go over, unfortunately, but that does give us a bit of a buffer there. But the hope is also that if you are attending our full data camp, that you have a minute to go stretch your legs, get some water, do what you need to do. So note those, most of our sessions are 50 minutes, and those breaks are built in. So with that, let's go ahead. And today's first session is going to be CDR Medicare claims. This session is going to be presented by Derek Cruikshank. And with that, I believe Derek wants to share his own deck today because he's going to be doing some pivoting between things as well, and it'll be easier for him to share himself. Derek, is that correct?
Yes, if that
okay, cool. I'll stop sharing now if that works for you.
All right. Yep. All right. Okay, cool. Yeah, so thank you for attending. Gonna talk a bit about Medicare claims within the CDR. I know there's been a lot of questions that have came in the past. There's a lot of requests about what is this, how do you utilize Medicare claims in the CDR, all that kind of stuff. So I kind of want to talk very briefly about, the billing process and how the claims actually get to us. But the majority of it's really going to talk specifically within the CDR, mainly around NCH claims, a little bit with the Part D DDPS claims, and we'll talk more about that. But also specifically, what are the differences between header and line tables? How do you use them? What is the all-important understanding of a claim segment and claim final action indicators? And then I'm going to, at the end, kind of walk through some example syntax, talk about best practices when it comes to actually querying claims. And of course, while I'm showing it, we can't actually show any of the data, but I can show some aggregations and some things like that that will help kind of understand a little bit about what's happening. So with that, we can talk a little bit about, how do claims get billed, and how does it come to us for us to then make it available in the CDR to all of the end users. So you have a Medicare beneficiary, and they could, go to some sort of Part A institutional type of a claim where maybe they're admitted into a hospital, maybe they're going to the emergency room, maybe they've got some kind of outpatient surgery. There's also, Part B claims where we talk about going with a basic checkup, or maybe they're going to some kind of mental health type of a um, appointment, or some kind of a durable medical equipment with like a wheelchair or a cane, of something of that sort. There's also, prescriptions. Obviously, the Part D prescription claims is a big thing right now within Congress, and trying to cap funding with how much out of pocket costs and all that stuff with Part D Medicare prescription claims. And then, of course, there's, other types of Part A institutional claims where maybe we're talking about home health agencies or some sort of hospice, if it comes down to an in-home hospice care. So ultimately, the process, you have hospitals, you've got physicians, you've got pharmacists, all that good stuff, and they are going to bill all of these claims to what are referred to as the Medicare Administrative Contractor, or a MAC. These are regional um, types of contacts, and they mainly serve as like an intermediary between the Medicare fee-for-service program, and all of the providers that are enrolled in those programs for actual Medicare itself. They service multiple states, and they're really in charge of administering Part A and Part B Medicare claims. Um, they then are servicing those claims, and they ultimately bring it into what is referred to as the NCH, or the National Claims History. And so the purpose of NCH is really to house all of the common working files that are processed within all of the details of the Medicare claims that kind of talk about Part A and Part B claims itself. And so these are going to be, initial claims, interim billed claims, any debit and credit adjustments. And it just basically means that they're really just like intermediary submitted claims that are then basically authorized, and they're either denied or validated. And it goes through to ultimately determine who's getting paid and what the amount of payment is going to be. It then goes into the NCH claims warehouse, where we then have the ability to run our own extract, transform, and load process, where really the majority of what we're doing is utilizing cloud technologies and Amazon Web Services to access the claims and do some transformations, do some final action determination, and then make them available within the central data repository for the end users to be able to access and pull. So let's talk about what types of claims there are within the CDR. Again, we'll start with NCH Part A claims. Part A claims are institutional insurance claims, meaning they basically cover, types of hospitals or physicians who work at specific hospitals, and it's really a variety of actual inpatient hospital care. There's skilled nursing facilities. There's, actual hospice. Maybe there's some kind of outpatient surgery or lab tests that are happening. And ultimately, it comes down to 5 different types of Part A claims that are stored within the CDR. The first one's going to be home health agencies. It's referred to as HHA. And it's really going to be any treatment for an illness or an injury within the beneficiary's home by a certified doctor or allowed practitioner. The next one is hospice, also referred to as HOSP. And those are going to be care and services for terminally ill beneficiaries, whether it's at an inpatient facility or perhaps it's an in-home stay type of a care. Of course, inpatient, that is going to be a very common one. And what you'll notice is within the CDR, we have tables referred to as IPSN. Those are going to be a combination of inpatient and skilled nursing facility claims. As far as actual inpatient claims, these are just going to be your hospital admissions and the services that were rendered when you were staying in the hospital. It talks about, including acute care hospitals, critical access, rehabilitation facilities, as well as psychiatric hospitals and long-term care facilities. Outpatient, these are your fee-for-service claims that are submitted by institutional outpatient providers. What does that mean? It means they're providers that are associated with hospitals that perhaps they're doing specific types of renal dialysis treatment, some kind of rehabilitation, mental health center within the community, or maybe they're doing some kind of outpatient surgery where it's like a colonoscopy sort of deal. And then, like I mentioned, the skilled nursing facility, which is basically just skilled care, nursing and therapy care that is safely and effectively performed under the supervision of some sort of professional or technical personnel, where people might be staying as sort of a temporary in between an inpatient care setting before they are then released at home on their own. Next is NCH Part B claims. These are going to be services or supplies that are needed to diagnose or treat, specific medical conditions, or healthcare that prevent illnesses or detect early on stage types of illnesses. There's basically two main types of Part B. There's the physician carrier claims, which are in the CARR tables. These are basically medically necessary and preventative services by physicians. So, like we talked about, doctor visits, mental health visits, ambulance services, maybe there's clinical researches. There's also the other concept of Part B claims, which is your durable medical equipment. These are referred to as DME, and these are going to be medically necessary supplies that are prescribed by a physician for in-home use. So this could be nebulizer treatments, walkers, wheelchairs, crutches, canes, whatever you could think of that might be needed within the home are durable medical equipment that could be rented or purchased through Medicare coverage. The last thing is our drug data processing system, also referred to as the DDPS, which is our Part D claims, which are prescription drugs. It also can include recommended shots and vaccinations, but for the vast majority of claims, it's going to be about specific prescriptions that were given to them and they went and fulfilled from a pharmacist. One thing to note currently, Part C, or what's commonly referred to as Medicare Advantage claims, they are not available in the CDR. We are actively working on creating a connection between the CDR utilizing Databricks and the IDR system that does have actual full Part C claims available, and that will be coming out relatively soon, hopefully perhaps around beginning stages of Q1 of next year, where we can connect and extract Part C Medicare Advantage claims. So let's talk about the two different types of the tables. There's going to be header tables and there's going to be line tables. So in the header level tables, this is where a lot of the summary information about the claim as a whole is stored. So we're talking about the beneficiary demographics, different types of billing and provider information, your international classification of disease, diagnosis and procedure codes, also referred to as ICD, which is currently ICD-10 when it comes to Part A institutional claims. One thing that is very important to understand in the vast majority of all of our header tables in the CDR, except for maybe a couple of different claim types, is that these claims are stored at a claim segment level and not at the claim level. And that's something that I'm going to touch on here coming up that will be very specific in understanding what a claim segment is and why that is not equivalent to an actual claim level. So the other type of table we have are the line tables. These are going to include all of the detailed information about the individual goods and services that were billed as part of that claim. So these are going to be very specific physicians that may be rendered services or were the operating physician on the claim. It's going to include specific payments about the types of services or goods that are being billed, and how much they cost. There's the place of services. There's your healthcare common procedure coding system and current procedural terminology codes, which is sort of HCPC CPT codes. And then, of course, on Part A institutional claims, there's your revenue center codes. And what's important to know is that each line has up to potentially 45 lines on a claim stored in that line table for each of the claim segments. And again, we'll touch a lot more about what that means and how that works a little bit later, which is right now. So what is a claim segment within the CDR? Claim segment, which is, this common column within on the header tables, is really just a way to identify claims records within the header data that also have associated lines on that claim that were billed. So what does that really mean? It means a single claim can have either one single claim segment, or it could have up to 10 claim segments. So if you're just pulling claims out of the header table and you're not specifying a specific claim segment number to pull from, you could be pulling claims. You could be pulling 10 potential records for a single claim. And that is basically because Part A inpatient claims have the ability for the hospitals to bill up to 450 lines on a single claim. But on the national claims history, they only store 45 maximum lines per claim segment. So because there's only 45 lines being stored, an example would be a claim that has 100 lines billed on it would have 3 claim segments associated with that claim in the header table. And we'll talk a lot more about that specific example in a minute. But one thing to note is that there is a claim surrogate key called that claim SK. However, this is a unique claim segment identifier. This is not a unique claim identifier. And this is what we use to join each claim segment within the header table and the line table to then bring in all of the associated lines that were billed for the claim. I realize that's a lot of words to talk about something very specific. So what we can do is show an example. Here's an example, like I talked about, of a claim that had 100 lines billed on it. So in the header table, you can see we have claim SK, we've got some other random fields, MBI, provider. Obviously, this is all fake data. And then we've got the claim segment number, 1, 2, and 3. So there are 3 claim segments associated with this specific claim in the header table. And the claim SK number is going to be different for each of those claim segments. And how that looks in the line table is going to be all of up to 45 lines on the claim are associated with a specific claim SK. So again, we talk about the first claim segment number has up to 45 associated lines in the line table, and it would link on that 1A claim SK value. We go to the second claim segment number, and now it has another 1 through 45 lines billed on this claim. So that's a total of a cumulative of 90 claims that we have, or 90 lines on the claim that are billed. And now the very final claim segment number of the third is going to have the up 1 through 10. And in total, that is 100 lines on this one single claim that has 3 segments in the header table. And one thing to note here is the NCH segment link number and the NCH daily processing date are 2 fields that you can see are identical across all of these claim segments within the header table. So these are system generated numbers by the NCH, and they can be used when you concatenate them to identify an actual unique claim identifier. So let's talk about claim final action quick. The final action indicator is a field that's included on the claims header table And it is something that is created during the transformation process in our ETL claims refresh that we include and identify what claim out of a claim group is the latest or the current claim based on the most recent weekly refresh. So those of you who maybe understand a little bit about claims billing and the concept of really accounting, a claim is either a debit or a credit when it comes in. An original claim that gets billed is considered a debit, and then there can be adjustments made on the claim. The claim can be canceled for several different reasons, or there could be different types of intermediate billing happening on the claim. So what happens is a claim can be submitted, being the original claim, and then a credit adjustment comes in, can be billed that cancels out the original claim with an actual adjusted claim that comes in as a new debit. And so what that all means is that a single claim can have many, many records submitted for that one claim throughout its entire life. And all submitted records are included for that claim in the CDR. However, only one of those records submitted is considered final as of a certain point in a given time. So again, this is a lot of words for something that we can show how it works specifically. Here is an example of how the final action can happen within the CDR, where we have an original claim submitted, and it is billed as a final claim, and it is the original debit. How do we know that? By looking at the claim query code in this FI claim action code. This tells us that this was the final claim and it is the original debit. Notice we have a claim effective date and a claim obsolete date, as well as a claim error signature SK value. With this in mind, we can see that this claim final action indicator comes in and it identifies this original submitted claim as true, meaning this is the final claim as of this point in time. So let's say an adjustment on this particular claim is billed later on. What happens is we have a specific cancel credit adjustment that gets billed, which is this first claim here, claim query code of 0, claim action code of 6. And notice that the claim error signature SK is a value of 3 here. Well, with the credit that canceled the original debit comes a secondary debit adjustment claim. So now we've got two claims that are coming in for this, two records that are coming in for this one single claim. Again, here, the second one is the adjusted debit claim. So now we're marking this with a -1, and the claim final action indicator is being equal to true. And so how our final action process works and how this claim would look in the CDR would be the following. You would have the very first record, the original claim, as not being final, but it does have this -1 value and it does have an effective and obsolete date. And then you have the canceled credit adjustment and then the new debit adjustment, which identifies this as being final. So when you go to pull this claim and you say, I want all claims that are final as of the most recent weekly refresh, you would get a single record for this claim coming back to you rather than all three of these records. So let's talk about really quick the difference between final claims and then claims that were final as of a point in time. The vast majority of the time, what we are going to do when we pull claims is we're going to pull claims that are final as of the most recent weekly refresh. So here's an example. We're pulling it from the header. We're filtering it on the claim through date, which is the partition. And we're filtering it on that claim final action indicator equal to true. Another thing to note is that it doesn't need to be a value of true. It can be a value equal to 1. 1 is equal to true within a binary. It does not matter if you use 1 or true. It should be the exact same value that you're pulling, the exact same records that you're going to get when you filter on claim final action indicator equal to 1 or true. So this is going to give us, if we pull this today, all final claims as of last week's most recent weekly refresh in the CDR for whatever claim through dates where services were rendered that we are extracting it for. There are some very rare occasions where people might want to pull claims that were final as of a certain point in time. How you can do that, again, is not by using that claim final action indicator, but by using a combination of the claim effective date, the claim obsolete date, and that claim error signature SK value. Like we showed here, this is going to be able to extract claims that were final as of a specific point in time, meaning the effective date was prior to the history, the point in time we want, and the obsolete date was after, and that claim was considered final as of one point in time. Again, we are still pulling on the partition date. So let's go one more slide here where we can talk about some overall best practices when you're pulling the claims data in the CDR. One thing that we highly, highly always recommend you do is you utilize the filtering of that header and line table partitioned column, which is claim through date. Note that for the DDPS Part D prescription drug claims, that partition is actually the RX service date. But by including this in your where statement with your filter, it is going to exponentially increase the amount of time it takes to pull these claims, especially if you're going with a large volume of claims, because of how the claims are distributed and they're stored across these partitions. Another best practice is to always filter on final claims. That way you're not pulling in claims that are not final as of that point in time, and you're not doing a whole bunch of unnecessary potential duplicated claims where some aren't final, some were final, and it's going to really exponentially increase the amount of volume in claims that you're actually pulling from. The only time I would ever suggest not pulling claims that were final is if you're researching, for whatever reason, a specific claim and what those submissions, bill submissions look like historically. But always make sure you're pulling claims that are final. When you are pulling header table data, particularly when you're using specific fields like condition codes or those ICD diagnosis codes or ICD procedure codes, you always want to filter on the very first claim segment number. Those are always going to be the most consistent and most complete across all of the claim segments for those particular columns and their values. What we found specifically with condition codes is that the very first claim segment will have the condition codes that were billed on the claim. And if there's a second, a third, a fourth segment on that same claim, it may not have any condition codes. So if you're including only header data that you need, you don't need to merge with line or anything of that sort, always consider pulling claim segment number equal to 1 in your filter so that you are not duplicating your claims. You're getting it at a base claim level, and the fields you're pulling in are going to be the most complete coming in from the NCH. The very last thing is just a suggestion as far as when you're pulling claims data, how you may want to store it internally. You probably are going to want to consider not storing your header base claim data merged with your line level data. What I've always done in the past is stored them separately as two different tables, where one is at the base claim level and one is at the line claim level. The reason for this is because the header tables, you can talk about having lots and lots of fields, right? There's 25 diagnosis codes, 25 procedure codes, 25 procedure dates, and then you get into actual, present on arrival diagnosis indicators, things of that nature, where we're talking about hundreds of fields that are going to have the exact same value across every single line. So if you're storing your header and line data together in a single table, you're going to have a lot of unnecessary storage where you've got all these codes being stored across every single line. And if there's lots of lines on the claims, you're going to have lots and lots of duplicated values that really aren't necessary to store together. All right, so that's enough talking. Let's show some actual code. So this is going to be available for everybody to view. Obviously, it's going to depend on whether or not your DUA access allows you to access the claims data. Particularly what I'm pulling is NCH claims, and then there is a little bit of the DDPS Part D claims. But what I want to talk about first is the difference between pulling claim level is compared to claim segment level. So in this first instance here, you can see what I'm simply doing is I'm pulling from the inpatient skilled nursing facility header table. I've got my claim through date, I've got my final action indicator, and then this NCH claim type code, which tells me the value equal to 60 is going to be inpatient claims. I then am going to simply aggregate this up and count it, and print it into an actual data frame where it's going to go ahead and count the claim SK values, so every single record across the year, month, formatted date. The second one here, I'm going to actually pull at the true claim level, where I'm going to say, I don't want all claim segments. I only want specific claim base level claims, right? So that is the addition of this claim segment number equal to 1. So I can execute this. And again, it's going to do the exact same dates, the exact same claim final action indicator, inpatient claims. It's going to do some counts of the claim. And then you're going to notice how significantly different these are when you pull it at a claim segment level versus a true claim level. And why it's important to make sure you're pulling it at the true claim level if you are aggregating things up and counting specific claims. So what you can see here is that on average, we're looking at about 1,300 additional records across these claim segments versus regular claim level, base claim level. So this means obviously a lot of these claims on average have more than one claim segment on them for that claim in the header table. So it's very important if you're going in and looking at a unique claim count that you are only including the first claim segment number on that claim count. So let's talk about a potential process that could be used when you're pulling claim and line level data. How I like to kind of do it, how I've done it a lot in the past, is sort of a 3-step process where we use the header table to identify all of the claim segments that we want, that we're interested in pulling. We write that to a temporary table, and we utilize that temporary table to link to the line table to bring in all of the associated lines that were billed on that claim. And then we also use that temporary claim segment table to filter on the claim segment number equal to 1, so that now we have 2 final tables at the end of the day, one at a line level and one at the base claim level, that we can then join back to each other on that NCH daily processing date and NCH segment link number fields that are unique claim identifiers. So here you can see I've got some example code where I'm just creating a list of diagnosis procedure fields to include in my SQL query. And here I'm pulling the initial claim segments. So again, Part A inpatient claims, I'm going to pull 6 months worth, and I want only those that are final as of the most recent claims refresh to create this sort of temporary claim segment table that we can then utilize to link up with the line table. And the reason why I want to pull all claim segments initially to link to the line table is because we need all of those claim SKs to make sure that we're pulling all of the lines that were billed. If we filter this on claim segment number equal to 1, we're not going to pull in all of the lines. If there was an inpatient claim that had over 45 lines billed on it, then we're not going to get those lines pulled because we didn't pull in the claim segment that's associated with those lines. So that ran. One other thing to note is that I'm creating a temporary view here because what I want to do is I know my actual line number values, as we saw in the presentation, they go 1 through 45. So those values are going to be duplicated across the segments. We don't want that. We want it to be cumulative. So I want this, instead of seeing 1 through 45, 1 through 45, 1 through 10, I want to see this going 1 through 100 cumulatively. So how we do that is we first pull all of the lines, and we're bringing in this line number. And then we do a little window function here where we're creating a row number over the partition of the unique claim identifier, which is this value here we're bringing in from the claim segment table and across the beneficiary. So this is going to allow us to have a new revenue center line number that doesn't have 1 through 45 duplicated across the same claim. It's going to have it cumulatively counted. And then here you can see I'm going to drop that view I created. And then I'm going to analyze and compute statistics on the table to take a look at the formatted layout of my final line table that I've created to just show, the number, like what is the table schema, what are the number of observations that I did pull at the line level for the claim segments. While that's running, the very last thing here you can see, I'm taking, again, that temporary segment level table, and I'm simply filtering it on the claim segment number equal to 1. So now I have my base claim table. And one thing to note is I'm using Spark SQL for a lot of this stuff because I'm keeping everything within a sort of database table or some kind of a temporary database view. This allows for it allows for the storage on the actual compute cluster to not bring it into memory. And so as I'm working with the database tables, in this temporary view, it's going to be all disk space and not the cluster's memory itself. So it really kind of helps identify, it helps kind of save some of the resource computing and memory and things like that, because I'm not bringing it into data frames because I don't need to yet. At this point in time, I'm just creating all this data up front to then be able to utilize further down the road if I want to bring it into a data frame. So here you can see I've got got to look at this, 72 million or so rows at the line level. And then we've got at the base claim level, this scrolls down for me. We've got 4 million rows. So obviously, you do the rate there and you can figure out, how many lines per claim there are. And you can kind of average out like the number of actual claim segments versus the number of actual true claims in that header table. So then at the end of the day, we've got a line table, we've got a base claim table. Maybe we want to bring some additional base claim fields onto the line level, right? And so that is easily doable because I've got two final tables here, one at the line, one at the base, and I've got this ability to go back and link them on that unique claim identifier field that was created at the very beginning when I pulled the claim segments, utilizing the NCH daily processing date and the NCH segment link number column. So by utilizing that field, I can merge them together. Maybe I want to bring all of the 25 diagnosis codes coming in at the base header table. Maybe I want to also bring in the CCN of the hospital, the claim from date. Maybe I want the DRG code and the bill type, right? So this is easily done where I can create this new table where it's kind of a baseline merge, again, using that unique claim identifier and the ability that these are stored in two separate tables allows us to not have one massive table that not only is incredibly long because of all the lines, but it's incredibly wide because of all of the columns that come on the header. So now we can kind of save a little bit of space, and we can see here I brought in all of these additional fields from the header table where I can now identify the number of rows that I've got that I've created. Okay, doing decent on timing. So let's talk another example where we can talk about comparing final claims versus claims that were final as of a point in time. So in this first one here, I'm going to go ahead and as you can see here, I'm pulling only the header table. So I'm going to keep that first claim segment number. And I'm only pulling claims that are currently final as of the most recent CDR weekly refresh date. So again, here, there's some additional fields that I'm bringing in for whatever reason. Doesn't really matter, but at the end of the day, this is going to give me all of the Part A outpatient claims between that had services rendered between these dates that are currently marked as final. And we're going to take a look, and obviously what you're going to see here is that the count of claims by claim final action is all going to have the same claim final action, where that value is equal to 1 or true, whichever value you want to use. The actual value in the field, because it's formatted as a binary data type, it's going to show true. But again, you can do equals 1, and it's going to show you that everything is final as of this point in time, as of the most recent refresh. The second piece here, I'm going to pull final claims as of a certain point in time. So again, notice that what I'm doing here is I'm pulling claims between April of 2023 and June of 2023, but I don't want to pull them, those that are final as of the most recent weekly refresh. I want to pull them that were final as of October 1st, 2023. So one thing to note that's going to be very important to understand is that these claims have what are referred to as they've got sort of like a lagging I'm completely drawn, of course I'm drawing a blank on the terminology that is commonly used, but like for them to become mature, right? There's a maturity of the most of all of the claims, right? So claims that have a claim through date that are more recent, like last month, those claims are going to take time to go through the billing process, to go through the validation process, to become final, to become stored within the NCH. And so when we look at, okay, we only want claims that were final as of last October, now we're going to probably see a lot less claims coming in because we haven't had as much time for the claims to mature and go through the billing process and the validation process of actually being approved and then coming in and being stored. So as you can note here, what we pulled is the 38 million records here between April and June of 2023. This is not going to be the same number of claims when we pull this as of October of 2023, because they haven't had nearly as much time to be able to mature and come in. And also another thing you're going to see is that claim final action indicator, meaning what that value is as of today, is going to be some of them are still final today, and others are not, meaning they're false, meaning there's been interim claims, adjustments on the claims, billed for that same claim that we have since processed and deemed that now this claim, final action indicator on this particular one, is no longer final today, but it was final as of a point in time. So here's the 38 million, but you can see we do have a lot less claims here. 38.083 million versus 38.832 million. So a lot less claims that we're pulling because they have not been processed. We've not allowed them to be processed as long. And there's a decent amount of them, 586,000 or so, that are marked today currently that, hey, these are no longer final as of today, but they were final as of October 1st, 2023. And then one last example to talk about real quick, and then we can get to some questions, is going to be pulling Part D prescription claims. How I'm going to do this is I'm going to pull this by beneficiary, fully recognizing that this is probably not the best approach to do because I'm not necessarily cross-referencing these beneficiaries. That is a whole nother topic for another data camp or potential office hour topic to talk about what does cross-referencing beneficiaries actually mean, and what's a common process when you want to pull claims historically for specific beneficiaries. High level, the idea here is that these MBI values can change over time. And so what you want to do is identify beneficiaries and all of their associated MBI values before you go in to then pull claims for them. That way you are certain that all the claims you're pulling are going to be all claims for that particular beneficiary you've identified. And then you have what the most current MBI is for that beneficiary. I'm sure there's people out there that understand what that means, and other people that I completely confused big time right there. But for the purpose of this demonstration and just these claims, what you can see here is I'm creating a unique list of MBI values that I pulled and identified from my Part A inpatient base level claims. And I'm going to write those to a table that I can then use as a sort of beneficiary finder table, lookup table, to pull all prescription drug claims for that same MBI value. Again, it's not perfect because there could be MBI values that one beneficiary might have multiples, but for the purpose of this, you can see here, I'm simply joining on the Part D table with my new table I've created here on the MBI ID values to then pull all final action as of the most recent weekly refresh and all of the actual prescription drugs claims in the fields that I want them for. So you can see here I had 2.8 million unique beneficiaries that had an inpatient stay. And I will pull all of those Part D drug prescription claims, looking at the RX service date, which again, that is going to be the partitioned column for the Part D claims. And we can look at, okay, how many unique beneficiaries are we seeing across the actual number of claims that were billed by this year-month grouping. I don't know if we have enough time. I do want to save some time for questions, and I know, Julie, I don't know if we were planning on a 10-minute break or not, but maybe we could just dive into some questions. Does that make?
Yeah, why don't we shorten that down to a 5-minute break, and that way we can get to a couple, but I definitely want to make sure we're at least getting a few minutes there for folks. So are you ready for me to start reading a couple?
Yeah, for
Okay,
sure.
cool. So let me look. There was a couple that I think you had started to mention on, so I would like to get to some new content. If it's on the agenda already, what are the filters required for as was processing? If I need to be able to reproduce results as of January 1st, 20XX, for
Yep.
example, are they the same as those for claims processing in the IDR?
Very similar. The concept of claim final action and like the requirements and the logic that's utilized um, in the CDR was mimicked after the IDR. So it should be very similar. And that is just simply what I talked about previously. When you want to pull claims as of a certain point in time, you utilize that claim effective date, the claim obsolete date, and that claim error signature SK value. And this will provide what claims were final as of a certain point in time um, in history. It is very similar to the IDR, yes.
Okay, thanks, Derek. Since CSTAT may be discontinued, could you tell us some key differences between CSTAT and NCH? And Derek, I'm sorry if any of these you've already touched on,
Nope.
just a newbie to the
Yeah,
content, so just let me know if you already did it.
this is a great question. So CSAT data, from my understanding, um, it's gonna be it's not gonna have nearly as many available claim columns as what is in the raw NCH claims. What is referred to as the base table is exactly what I talked about when you filter the header table to the first claim segment number. Um, so CSAT claims they're not at claim segments. They have a base table and a line table. And I believe they only pull um, part A inpatient. I don't know if they might pull part A outpatient and then also part B carrier. I don't think they do durable medical equipment and like hospice and home health agency and stuff like that. I can't recall off the top of my head. It's been a while. But yeah, the CSAT claims. My also another understanding is that they have specific maturity levels where it's like they've got so many months of maturity on them, which is what I talked about here. If you were to pull claims that had a claim through date of, you know, October 1st, well, it's only oh my God, it's only November 13th. That so claims that have a claim through date on October 1st have not had a lot of maturity. They've had only a month and not even a half yet. And so the idea is that it can take up to potentially 6 months for claims to mature prior to when you go to pull them. So you want to give a little bit of a buffer to allow those claims to go through the billing process, allow for some of them to become what is quote unquote matured, and made it through the process into the database and the systems, so that those claims are available the date when you pull them. And so like the ideal state is like you'd have like 6 months to 12 months or so when you go to pull the claims, um like going backwards, right? So if I'm pulling claims that were billed June 1st, 2024, and I'm pulling them in December 2024, those claims have had, not all of them have had a full 6 months maturity, but some of them would. And so the further back you go in the history that you're pulling them, those are going to be more and more mature as they're coming in. Um, Hopefully that makes a little bit of sense about what CSAT is doing there, because I think they do like they do two different types of maturity. But the main point is that CSAT does rename the columns. And so certainly if CSAT's going away, we could very easily take a look at, the owner of CSAT could take a look at, here's all of the column names and what they map back to on the raw NCH and DDPS claim fields, so that you all know what you've been utilizing and what that maps back to with the actual NCH tables and what those columns are.
Thanks, Derek. I think at this point we need to wrap up our first session. I do want to give everyone just a quick 5-minute break prior to moving into that next session for the day. So our next session is going to be session 7, SAS to Python conversion, introduction to SAS to PyTool. So Derek, you're getting praise in the chat right now. And then I do want to note that I know that we got several questions that we did not get answered. So I'll make sure I got those recorded, wrote them down, and I'll pass those along to Derek so we can get those answered. And as I mentioned before, all questions will be published. We had a question in the chat as well. Just to reiterate, all decks, materials, resources, the recording, the notebooks, all of that, and the Q&A will all be published in Portal. You'll just have to give us a few days to turn those materials around and get them 508 compliant and accessible. And then outside of that, everything will be turned over to our presenters, or if we get any questions after the fact. So I'll get those to Derek. And at this point, we are going to wrap up session 1. Thank you so much for joining us. Thank you so much, Derek, for the great presentation. And we'll see you all at 2 o'clock to kick off session 7. Thank you.